Everybody, thank you for being here today. Also, thank you for the GLOHRA series, to Walter, Esther, Maeve, and the others for the great technical support and the invitation. There have been very interesting talks until today, and I feel very privileged to be here today, especially as an early career researcher myself, and speak about a topic which I think, especially during these times that we are having here, is from fundamental importance. It's global mental health. I will present some results from research that I've been conducting, obviously all together with many different colleagues here at the Charité Campus Benjamin Franklin. And I would also send you during this time, first of all, a lot of compassion and also strength during these hectic times. And I'm happy that we're here together and maybe can see a little bit more on how we can have impact on global health in general, and with that also to global mental health. So I think we already started with a question here. How many people at about have a mental disorder, including substance misuse disorders? And it's more than 970 million according to actual figures. Obviously, these are also estimates. There's an at the board number just to have an imagination of how many people in the world suffer from these disorders. But before we maybe jump right into mental disorders, the word mental health is gaining popularity, and it is something that we all have. And mental health can be understood as a dimension. I'm happy that I'm here able to use a slide which I think suits it perfectly, together by Professor Saxena, a well-known figure in the field of global mental health. And I think it shows very well the dimensions of, on the left side, positive mental health, going over to mental distress, what we could experience all, going further to the dimensions of mental disorders, and lastly to approaches of the field of psychosocial disability. And maybe we have all seen us here now on this continuum and these dimensions on a different part. And the COVID pandemic during the two last years has already been quite a, we could say, and consider this as a chronic stressor. So we all might have been moving a little bit from the left to the right, regardless of where we are standing. Now, in times even of war, what we could have not even imagined a couple of weeks ago, we maybe even as another further stressor move even further to the right. So what this tells us a lot about mental health is that mental health in itself, in its essence, could also be considered flexible and changing. Just because one has experienced a mental disorder doesn't mean that he can also fluctuate back much more to the left. Having this in mind, this I think is a quite beautiful illustration of Patel and colleagues, also very famous researcher from the States, originally from India, published in The Lancet, of a staging approach. I don't want to go too much into detail, but what I think shows it quite well is on the figure when you look in the upper part, that there are aspects like insomnia, worry, or lack of energy, possibly all things we have experienced more or less during last years, maybe before and even after, and even goes further to slowed thought, anxiety, or aberrant salience, low mood, resulting further along these dimensions. The more it goes down, the more the stages come more concrete to mental disorders. So in the end, you see very specific syndrome dimensions that then come together to disorders such as anxiety disorders, mood disorders, for example, psychotic disorders, well-known schizophrenia as an example. Why now global mental health specifically? Well, first of all, numbers of different mental health disorders, for example, as anxiety disorders, major depressive disorders, from the years 1990 on the picture on the left to 2017 have been steadily increasing. When we look on the right side, there is the world average in green, going up from 3% to at about 5%. We see specifically in low middle income countries that these numbers are increasing, but specifically this shows us that common mental health disorders and addiction disorders are responsible for 70% of global disease burden. Moreover, there's high comorbidity with other medical conditions, there is a bidirectional relationship between mental and physical health. So if there are people here around from physical health disciplines, well, we've been working together on different, on the same illnesses and disorders, which I will come back more. So an interdisciplinary approach is already something very useful at this point. Now, this is a paper from the Lancet and Lancet Psychiatry, published very early early in time last year and this year. Very large global burden of disease study, and it shows quite well, encompassing more than 204 countries, what happened due to the COVID pandemic, showing us, for example, that numbers of anxiety and depression prevalences are increasing, and it has obviously a results on the DALYs and GLDS. And we can even see on the females and males part on the picture on the right side that there is an additional increase of, for example, common mental health disorders. So this is, and some people even declare a pandemic which will result after, if it comes to the point of the COVID pandemic. Just specifically for anxiety disorders during the COVID pandemic and before, you can see here well on the left side for females in the blue lines, the numbers on the left side, prevalence per 100,000 and the age years. You can see it is encompassing pretty much all age ranges. And we see clear increase from before to during the pandemic. And maybe you have friends, relatives, or yourself experiencing this. And what I would say at this point is it is quite normal and an understandable reaction to what's been happening. But at the same time, as psychologists, psychiatrists, people working in the field of mental health, it is an urgent call we have to look for. Giving, for example, the high prevalence of depression, we see here on the left side, clear increase throughout the past decades. And major depressive is currently among the 10 leading causes for years lost due to disability, and has a clear impact and will most probably be by 2030 among the highest when it comes to global disability life years lost due to disability in 2030. Just shortly had to change something, apologize. Now, I just need one moment to fix this here, please. Yeah. Moreover, comorbid depression is something happening in many chronic medical diseases. Here, just to name a few, among cancer, cardiometabolic, neurological, and inflammatory disorders and sicknesses, we can see here the prevalence is increased by 2 to 3 times. So having an eye for mental illness in other disciplines is very important. Looking at the personal burden specifically now for major depressive disorder, we see it is significant and wide-ranging. It has impact on the marital dissatisfaction, negative parenting behaviors, which are strongly related to symptoms of depression. MDD is significantly associated, according to many studies, to chronic physical disorders, as I've mentioned, specifically arthritis, asthma, cancer, diabetes, or cardiovascular diseases. It has results in affecting personal earnings and household income of people with MDD, which are substantially lower than those without depression. And also people with MDD have the highest number of days away from work of any physical or mental disorder. One could say reducing the burden of MDD is a global challenge. It is encompassing a variety of stakeholders and treatment possibilities, and also the community, encompassing healthcare practitioners, decision makers, researchers, and the general community. One could say that a real flagship in all of this has been the WHO Mental Health Initiative, has been now extended to 2030. And the action plan is showing clearly that for healthy populations, On an international level, it is a central part of the SDGs, specifically health and well-being, but it's also an essential part of healthy populations in also decreasing substance abuses and needing a healthy environment overall. From our research now, from our research group specifically, along from Professor Boschbusch, Dr. Hahn, and Dr. Tah, there have been grand challenges named in editorial and Frontiers of Psychiatry I can only recommend, but also by Patel and colleagues in Lancet, which are actually quite clear what we have to look for. We have to have a special eye for conflict settings, which we are facing right now, health disparities, needing to increase public awareness, overcome stigma, to which I will speak more about. We need more concrete access to medicine. We have to consider the collateral damages on mental health due to pandemic. I've mentioned briefly before. We have to consider climate crisis in itself, oncoming, and possibly its impact due to flight. But also it gives us possibilities with new technologies and also increasing and strengthening the overall resilience of our healthcare and specifically mental health care system. Now, with a background now to global mental health, I would like to speak more about our global mental health research group at the Charité, which has been funded by different funders and is encompassing a variety of work. For today, I will jump into two projects more specifically, just to give you a view of what our work has been. In general, our approach is to include participant and stakeholder perspectives of mental health. Our interdisciplinary group has now published numerous studies assessing recommendations, treatment options, treatment providers, also how to strengthen mental health care systems involving policymakers, stakeholders in specific countries. Our work has been including Vietnam, India, Turkey, Germany, Jordan, Ghana, Syria, Kurdistan, Iraq, and Iran. With this work now, I will also like now specifically to speak about our work in Vietnam for the next slides, giving you an overview of what we've been conducting. Feel always free to contact me later if you're interested in any other of these works. And I'm seeing lately also another country that I missed now in this setting, which is Jordan. This is, for example, the work that we have been now contributing to the schizophrenia working group in the field of genetics, where Professor Ripke from the Charité is also a key member. On the left side down, you see a paper from 2014, a very great international collaboration, including more than roughly 35,000 patients, 110,000 control conditions, and been showing that 100 specific loci could be identified for schizophrenia. Now there is a new paper coming out, which has been shown to have more than 270 loci, showing that, for example, schizophrenia, as many other mental disorders, also are polygenic. What we did here, for example, together with our partners of Vietnam, which you see in the upper paper here, is introducing a further sample to increase the diversification of samples in GWAS studies. Besides genetic approach, we have also done conducted population-based approaches. This, for example, here is some work that we conducted in the greater area of Hanoi, where we did a representative population strata-based survey, more than 29 districts included. And there already it starts. The work together with partners in the local settings, and this, it was the Military Academy Medicine and Hospital 3, in which we included more than 1,000 participants. Out of this, multiple papers have emerged, out of which we assessed, for example, treatment recommendation differences between schizophrenia and major depression, which is specifically important because this gives us an understanding of the overall mental health literacy in the population, and then gives more, better, clearer recommendation also for policymakers. We were able to assess, for example, how attitudes and stigma towards mental health care facilities, but also professionals, what could be factors, for example, possible religiosity, what we were able to show, or for example, that people with male gender seem to have more negative attitudes towards psychiatrists. And with this knowledge, obviously, we can do much more detailed and precise, for example, mental health campaigns. We can include religious institutions in further destigmatizing campaigns and see the treatment of mental health in a sense also on a community-based level. Lately, or more precisely, for many years now, this has been funded very well and happily by the BMZ, also the GIZ and the clinical partnership, which I think you have also heard from Dr. Kantelhardt and her great work. And we are very happy throughout the past years to have increased the mental health care professionals, psychiatrists. I saw also that some colleagues of Vietnam are here in today, which is great. I would like to jump also on another topic which is emerging the past years. I think we all have experienced and seen the results of war and the refugee crisis. This is another field of interest to us. And here, this is a meta-analysis. We were able to show that from all refugees studies that were performed in Germany, PTS was in about 30%. 40% had depressive symptoms, showing this very high numbers and the need for treatment. So when we look into treatment needs, we did, for example, trials and studies specifically in Jordan or Kurdistan, looking into the specific preferences and expectations of different host communities. And what we were able here, for example, to show was that in general, when treatment was given, the satisfaction was very high. And also the acceptance towards the therapist. But for example, other nuances were important. They were shown to be gender and differences concerning national politics, which were important to the people receiving the therapy, guiding us in understanding what kind of therapeutic settings might be useful. We found, for example, that if the therapies were conducted, they were experienced very well. However, we also experienced mixed results when it came, for example, to different minority groups and increased stigma also among those, if it came to the point that people were having a therapist which were, for example, from another minority group. So these are all aspects in multicultural countries with different minority groups to consider. Our activities in general encompass specialized interventions, low threshold interventions, training and supervision, specifically research in developing culturally adapted scales, treatments, and novel psychotherapeutic approaches. Just one trial that I would like to mention, which was a multi-center trial in response to the high need, to the high mental health need among refugees, was the Mihira trial. This is a study protocol of a stepped and collaborative care approach, which aims to give participants treatments which are then in accordance to the symptom severity, from lower threshold intervention to specialized interventions, which you can see on the left side in the figure on level 4. It was a classical randomized controlled trial with 2 groups, and we compared this to the overall German treatment as usual. This was a highly ambitious trial funded by the GWA and the BMG with many well-known psychiatrists and psychologists in Germany. It was a multi-center trial. And there we developed multiple new novel cultural sensitive approaches. We developed an application, an empowerment, and as well peer-to-peer interventions, which I think are very promising, taking people out of these groups from the refugee community and training them specifically to give then treatment to participants, which I think was very valuable and which we did through also qualitative studies. Because here specifically, when we speak about digital interventions, this was an app, we named it Balsam, and this app was delivered, for example, on level 2, so rather for milder depressive symptoms. And it included a storytelling approach, quite different from other applications currently available, where a person was guided through different stages of a flight, of acculturation, and showing different kind of stress management techniques, and also to detect stress patterns by using digital technologies and giving direct feedback. This overall trial showed very promising outcomes currently being in review in Lancet Regional Health. Here on the left side, you could see that we were able to decrease depressive symptoms self-assessed by the PHQ or rater-based by the MADRS, which are very well validated depressive tools. And we were able to ameliorate depressive symptoms in the active condition much stronger and compared to the count condition, which in this point was the blue, and the red ones showing the intervention itself. These were very great results, and you could also see on the right side that our proposed model was cost efficient compared to the overall mental health care system. In general, you see here that in general, the Tau condition in Germany, the mental health care system was very strong, was able to ameliorate systems, but our more specified treatment intervention was able to decrease the symptoms even more. Now, there's already other approaches, for example, by the WHO. It's called the Problem Management Plus manual, which can be easily accessed through the internet. It shows more psychological intervention in simplified versions, so-called low-intensity psychological interventions, which have been also translated into many languages, and which can be also easily used and implemented to give, for example, also community-based treatments. Just to give a very quick and easy example and how to illustrate and show someone with depressive symptoms how low mood can lead to inactivity on the right side and withdrawal, which obviously then fosters low mood, leads to even further inactivity and withdrawal. This can be already quite helpful for people who at least experience mild symptoms of depression. In our other research, we, for example, looked into what kind of symptoms refugees were actually representing, which was very interesting. Specifically, they showed feeling down, depressed, and hopelessness, trouble falling asleep, and feeling tired, but also on a somatic dimension, troubling sleeping, feeling tired, having low energy, specifically low concentration, and back pain. So this can also give health literacy on both sides, for the people who are treating, also for the screening processes themselves, but also for individuals in understanding and also to get a clearer perspective of what is happening within. This has been a great work from a colleague of mine, Karin Kanouk, who did her PhD in this. She realized, coming herself from an Arabic-speaking country, that there aren't that many cultural sensitive tools in assessing, for example, these symptoms. The Mini is a very well-known tool, which is primarily used in Western countries. And what she did was a translation of this tool, but much more, she incorporated people out of the communities. She took people from different countries from the Middle East through a process of translation, and then specifically cultural and linguistic adaptation, which you can see here, for example, where you see on the right side, for example, the explanation, down, sad. The term down can't be used to describe emotions in the Arabic language, showing that just a simple translation of such scales don't work. That we need people also who are culturally and also linguistically embedded in that cultures, working together with people in that sense to translate such scales. Now, all of this work actually comes together to, I think, one of the most important points, and that is the topic of stigma. You are not your mental illness. Is something that even today, as I'm here in my room also treating patients, for example, with schizophrenia, is something very important, something I still hear from other people, words, for example, like this person is schizophrenic, rather than considering that this person has schizophrenia. So you are a person with a mental disorder. You are not only your mental disorder, and languages and also the way how we think are shaping the way on how we speak with each other, how we name things. And this, of course, all accumulates together to self-stigmatization. But self-stigmatization goes also further. There are other levels of stigma, structural stigma, which leads also to discrimination against people with a mental illness by legislators and insurance companies. We also have public stigma, which leads to points like discrimination in job applications. Also for family members, the topic of guilt and shame. So the importance of stigma for global mental health is wide. And In this context, it is important that stigma is not only harmful, but it's also measurable and changeable. And stigma processes are a global phenomenon and therefore from uppermost importance, but we must be examined and interpreted in individual social cultural context, because stigma affects not only individual conditions, but disease-wide. And this has been well studied, for example, in co-occurrence of mental illnesses with HIV and obesity. But moreover, stigma is also understood intersectional as a set of conditions, as an interplay of social class, of ethnicity, of racism, of gender, of sexual orientation, or religious affiliation or exclusion. For example, in Iran, homosexuality is stigmatized by the ruling class as a mental disorder and a Western influence at the same time. And also that homosexuality is a contradiction with Islam. But we find this in a variety of cultures and countries. The good part is that there are 5 overall principles and strategies to change stigma, just to be named of a few, in accordance with the contact hypothesis, contact with affected individuals, targeting the conflict in different dimensions, for example, in schools, local contacting, and also increasing the credibility and continuity. All of these aspects here now today mentioned together are social determinants which include a range of social and economic factors and that influence mental health of population, such as structural, social, and economic arrangements that confer advantage or disadvantage from conception to old age, but also to differential exposure to adverse life events, to specific conditions, vulnerabilities, and resilience, and that these arrangements or exposures in all produce. And many of the SDGs, which you can see here on the left side, also explicitly address the social determinants, and progress towards the attainment has the potential to promote mental health in general and to reduce the global burden of mental disorders, the inequity, the distribution of mental health disorders in all overall populations. So this is a slide to, I think, finish with, given by the GLOHRA Academy Series. And I think global health research is inter and also transdisciplinary. It needs to consider economic, social, cultural, but also environmental and political factors besides the obvious psychological ones. I think it is also part of creativity because we have to think out of the box. And also global health research is a global challenge, but I feel it's also an opportunity. I think in the words of Yuval Harari, which I like a lot, global health research could also be seen as a collaborative work in the essence of science in it itself to transform and progress, considering humans and their development all over. In that regard, I would like to thank multiple funders for this work. I'm just here now privileged and honored to present these results, but there has been many people in this involved from a variety of countries. And we appreciate that we've all been working and will still work on increasing global mental health and its awareness. I would like to finish with a picture from 2018 at the symposium with our colleagues in Hanoi in Vietnam before the pandemic. And I appreciate all of your attention. I'm looking forward for a lively discussion.